This is Vidya Krishnan. I'm an associate professor at the School of Medicine at Case Western Reserve University, Metro Health Medical Center campus in pulmonary, critical care, and sleep medicine, and I'm going to talk to you about lung volumes. Just to get the nomenclature straight, we have lung volumes and lung capacities. Lung volumes are the discrete volumes of the lungs, and they can be characterized specifically, whereas lung capacities are the sums of different lung volumes. We'll start with the easiest one, total lung capacity. TLC is the total air volume in the lung. When compared to predictive normal values, TLC can be normal, high in COPD or other obstructive lung disease where there's hyperexpansion, or low as in interstitial lung disease or neuromuscular disease processes where there's restrictive lung disease and TLC is low. Total lung capacity is comprised of the vital capacity, VC, plus the residual volume, RV. The vital capacity is that amount of air that's able to be breathed in and out by a patient. The graphic is showing normal tidal breaths, followed by a forceful inspiration and expiration by a patient. The residual volume is the volume of air left in the lung despite full forceful expiration. In spirometry, we can depict what the patient is doing by volume time curves. This is sort of a busy graphic, but I'll walk you through it. In a normal patient, as depicted in the black line, the patient exhales forcefully at time 0 and exhales as much as they can until they reach a plateau. At 1 second, the amount of volume that is exhaled is depicted by the blue dotted line, is the forced expired volume at 1 second. The plateau that is reached is their forced vital capacity. In a patient with restrictive lung disease, regardless of the cause, this is depicted in the green line. There's a forced exhalation at time 0, but the plateau is achieved at a much lower volume. This is the forced vital capacity that's reduced in these patients with restriction. And as a result of the forced vital capacity being reduced, the FEV1 for these patients is also measured as reduced. And so there is a corresponding reduction of both FEV1 and FVC in these patients with restriction. In patients with obstruction, as depicted in the orange graphic, there is a forceful exhalation at time 0, but there's a slow exhalation. And so FEV1 is reduced because there's not as much volume that is exhaled at 1 second. And this exhalation can continue on. At an arbitrary number of 6 seconds, we can measure patients' forced vital capacity, and it may plateau at this point, which can tell us what their vital capacity may be, or patients with obstruction may continue to exhale beyond the 6 seconds, and the forced vital capacity may actually underestimate their true vital capacity, which is at the point where their line plateaus.
The next step is to understand the different volumes of the lung. We've talked about the residual volume, which is the volume of air left in the lung after full, forceful expiration. Tidal volumes are easy to understand. Those are those normal breaths that are taken and the volume that is moved in and out during a normal breath. The expiratory reserve volume is the additional air that can be exhaled after a tidal breath. The inspiratory volume is the additional air that can be moved with inspiration above and beyond a normal tidal volume breath. In a normal tidal volume breath, inspiration requires muscle strength. It's an active process, whereas expiration is involuntary and relies on the recoil of the lungs. The inspiratory reserve volume depends on muscle strength. That is not only the diaphragm, but the external intercostal muscles. And the expiratory reserve volume also depends on muscle strength. That's the abdominal rectus muscles and the internal intercostal muscles. We can also think of splitting total lung capacity into the inspiratory capacity, IC, and the functional residual capacity, FRC. Inspiratory capacity is that amount of air that can be voluntarily inhaled. There are some studies to suggest that this might be a better marker for COPD severity. Functional residual capacity gets my gold star in terms of pulmonary physiology. It is comprised of the expiratory reserve volume plus the residual volume. The FRC holds a special place because it has unique features. When we think about pulmonary compliance, the FRC is the lowest transmural pressure point. This is a graphic of the total pulmonary compliance. This black curve is the chest wall compliance. This black curve is the lung parenchymal compliance. The sum of these two curves is the total pulmonary compliance. At the point where the transmural pressure is the lowest is the functional residual capacity, the FRC. When we talk about total pulmonary vascular resistance, FRC is also an important milestone. The pulmonary vascular resistance refers to the vascular resistance in the pulmonary circulation. Blood vessels in the alveolar areas increase in resistance with increasing lung volumes, as is seen in the purple curve. In the extraalveolar spaces, blood vessels have decreased resistance with increasing lung volumes, as is seen in the green curve. The sum of these two curves represents the total pulmonary vascular resistance. The lowest point in that curve occurs during functional residual capacity, FRC. So those unique features of the functional residual capacity, FRC, includes the point in the breathing cycle with the lowest alveolar transmural pressure and the point in the breathing cycle with the lowest total pulmonary vascular resistance. And this is the reason why, by convention, when we're measuring hemodynamics, we measure them at FRC. We measure things like central venous pressures and pulmonary capillary wedge pressures at FRC because this is the point where the effects of compliance and vascular resistance are the lowest on these hemodynamics. In addition, FRC represents the oxygen reservoir for the pulmonary system. At the end of a normal tidal breath, this is the amount of air that's left over that can hold oxygen. So in the case of an apnea or hypoventilation, the oxygen remaining in the lung can still be distributed to the body. This oxygen reservoir capacity also represents a major function of the functional residual capacity. So that is my summary of lung volumes and lung capacities. The lung volumes being inspiratory reserve volume, tidal volume, expiratory reserve volume, and the residual volume. The capacities being the total lung capacity, the vital capacity, the inspiratory capacity, and last but certainly not least, the functional residual capacity. Thank you very much.